The musculoskeletal system provides the structure, support, protection, and movement required for daily activities. Understanding anatomy and basic pathophys helps you recognize changes, complications, and disease processes seen in patient care. Bones are hard, dense connective tissues forming the skeleton. They function by supporting the body structure, protecting vital organs, movement, hematopoiesis or blood cell production in bone marrow, and mineral storage of calcium and phosphorus. Bones can weaken with osteoporosis, osteoarthritis, fractures, or osteomyelitis. Healing of bones involves inflammation, a soft callus, hard callus, and ultimately remodeling. The joints connect the bones and allow movement. Synovial joints are most common. They are the knee, hip, and shoulder. They contain cartilage, a joint capsule, and synovial fluid. Fibrous joints are sutures of the skull, and cartilaginous joints are the vertebral discs. Pathophysiology that affects bones is arthritis, osteo, psoriatic, and rheumatoid, joint instability, and synovitis. There are three types of muscles: skeletal or striated, which attaches bones to bone and has voluntary movement; smooth, which is the organs are involuntary; and cardiac, which of course is your heart. Skeletal muscles contract to move bones through tendons. Tendons are tough fibrous connective tissues that connect muscle to bone. They transmit muscle force to bone to create movement. Pathophysiology of tendons is tendinitis, tendon ruptures, strain injuries, and degeneration. How do these structures work together? Well, bones provide the structure, joints provide the motion, muscles create the movement, and tendons transmit force. Damage to any one part of the whole system results in pain, limited movement, and decreased function. Important pathophysiological themes to remember. Inflammation occurs with fractures, sprains, arthritis, and soft tissue injuries. Degeneration is when cartilage is worn out or weakened bones for osteoporosis. Trauma injures bones, joints, ligaments, muscles, and tendons. Immobility leads to muscle wasting, joint stiffness, DVT, and skin breakdown. And circulatory changes. Good circulation is essential for healing. Poor circulation is delayed healing or even results in amputation. The long bones, such as the humerus, radius, tibia, and femur, are in the appendicular skeleton. Functionally, the long bones function as levers in mobility. They are comprised of the diaphysis and the epiphysis. The diaphysis is a long cylindrical shaft. Within the shaft is the medullary cavity, which contains red and yellow bone marrow. Another component of bones is the epiphyseal growth plates. The epiphyseal growth plate is primarily hyaline cartilage and contains 4 regions. Short bones include the carpal bones in the hands, as well as the tarsal bones located within the feet. Flat bones, such as the bones of the skull, ribs, and scapula, are found in the axial skeleton. Irregular bones, such as vertebra and the pelvis, are bones that do not fit into any other category of bones. Bones in the human body are connected to each other through joints. These joints allow the skeleton to move in different ways. The most common type of joint is synovial joint, which is freely movable and includes examples like shoulders, knees, and hips. Synovial joints contain a fluid-filled cavity that helps reduce friction and allows for smooth movement. Movement of the skeletal system is made possible by muscles, particularly skeletal or striated muscles. These muscles are under voluntary control, meaning we can consciously direct their actions. They attach to bones through long, strong, fibrous connective tissues called tendons. When skeletal muscles contract, they pull on the bones they're attached to, creating movement at the joints. The ability to move freely involves intact musculoskeletal and nervous systems. Alterations within these systems can result in immobility An immobility may be temporary, such as a strain or sprain, or a chronic condition, such as with Parkinson's or arthritis. Aging increases the likelihood of suffering from a movement disorder, but it affects people of all ages. Musculoskeletal disorders are the leading contributor to workforce concerns, as many musculoskeletal disorders lead to disability and early retirement. The cost of immobility includes the financial concerns of prolonged hospital stays, medications, treatments, along with the psychosocial concern of a lower quality of life. Conditions affecting the bones include disorders such as osteoporosis and osteopenia. An example of a condition that affects muscles is sarcopenia. Sarcopenia is the age-related progressive loss of muscle mass and strength. The main symptom of the condition is muscle weakness. Sarcopenia is a type of muscle atrophy primarily caused by the natural aging process. Scientists believe that being physically inactive and eating an unhealthy diet can contribute to the disease. Diseases such as Huntington's disease and Wilson's disease may be inherited or genetic dispositions. Tardive dyskinesia, or TD, is due to long-term use of certain medications used to treat disorders such as Parkinson's. Pain is one of the physical factors affecting mobility. Pain may be caused by an initial injury, the disease process, or a surgical repair. Problems with mobility may be present without any concurrent disease or may result from an existing disease or procedure. The client undergoing a surgical procedure, regardless of the cause, is at risk for developing problems with mobility. The existence of chronic respiratory or cardiovascular conditions, such as COPD or heart failure, may restrict the client's endurance during movement. Chronic neurological problems may lead to immobility. Immobility can lead to an increased risk of development of comorbidities, such as cardiovascular disease, venous thrombolism, respiratory complications, and respiratory conditions. There are many health challenges that the client with an alteration in mobility may cope with. These challenges include physiological and psychosocial issues. Both mental and physical decline can occur quickly. Clients dealing with alterations in mobility may face several physiological impacts to their overall health. These challenges include loss of function and physical conditioning. The longer the period of immobility, the greater the risk for loss of muscle mass. Complications of immobility can include confusion, depression, decreased cardiac output, venous stasis, DVT, pneumonia, decreased cough reflex, decreased lung expansion, swallowing difficulties, incontinence, constipation, bowel dysfunction, heartburn, aspiration, UTI, skin breakdown, pressure injuries, infections, and inflammation. Clients coping with alterations in mobility may face psychosocial concerns. The client may experience frustration and depression at the loss of independence. With prolonged immobility, the client may also experience a loss of cognitive function. A loss of confidence may lead to further problems with mobility as it increases the risk for falls. The musculoskeletal system goes through many changes throughout the lifespan. Bone density begins to decrease after about age 30. In menopausal clients, the loss is accelerated and the bones become more fragile. There are also changes affecting the connective tissue and cartilage in the joints during aging. The cartilage becomes thinner and resilience in the joints declines. Because of this, the joints are more susceptible to damage. In some clients, this may lead to osteoarthritis due to the joint's inability to glide or slide over each other. The ligaments and tendons are also made of connective tissues, and aging causes the ligaments and tendons to become more rigid and brittle. The aging individual may also experience a loss in range of motion. Like the bones, the adult begins to experience a loss of muscle mass at about age 30, and it progresses throughout the rest of their life. This is known as sarcopenia. Along with the loss of muscle mass, sarcopenia also results in loss of strength. This muscle loss adds stress to some of the joints and can lead to an increased risk for falling and arthritis. Loss of muscle mass can be overcome or delayed with regular physical activity. Take a moment and consider complications to include pressure injuries, pneumonia, confusion, depression, venous stasis or DVTs, orthostatic hypotension, incontinence, and constipation. Several health conditions can lead to changes or limitations in mobility by affecting the joints, muscles, or bones. Synovitis is the inflammation of the synovial membrane, the lining of the synovial joints. When this membrane becomes irritated, it produces excess fluid, causing pain, swelling, and reduced range of motion. Arthritis is a broad term used for inflammation of the joints. It can result from autoimmune processes, wear and tear, or infection. Regardless of the cause, arthritis leads to pain, stiffness, and decreased mobility. Muscle atrophy refers to the wasting or shrinking of muscle tissues. It often occurs with inactivity, aging, or certain medical conditions. As muscle mass decreases, strength and mobility decline as well. Osteoporosis affects the bones themselves. With this condition, bones become porous, fragile, and more prone to fractures. Even small stresses can cause breaks, significantly limiting mobility and independence. Osteoarthritis is the most common form of arthritis. It involves the gradual breakdown of cartilage in weight-bearing joints like knees, hips, and spine. Over time, the joints become stiff, painful, and less functional. Each one of these conditions interferes with the normal function of the musculoskeletal system, leading to decreased mobility and impacting activities of daily living. Synovitis can be caused by a contusion or sprain, repetitive motion, or disease processes such as rheumatological diseases or infection. The manifestations include painful joints that worsen with movement and swelling at night. Full extension of the affected limb is not possible without an increase in pain. Diagnostics will include ultrasound, possible MRI, and aspiration of fluid. There are more than 100 types of arthritis. There are many different causes. These causes not only include aging, but also autoimmune disorders, viral and bacterial infections, or damage to the articular cartilage. Additionally, sometimes the cause remains unknown. Diagnostics include X-rays of the affected joint, looking at both the anterior, posterior, and lateral views. An ultrasound may be used for diagnostic purposes and to assist with removing fluid through an arthrocentesis. Osteoporosis can be primary or secondary. Primary causes include aging, gonadal insufficiency, decreased calcium intake, and low vitamin D levels. During bone remodeling, there is an increase in bone reabsorption resulting in a decrease in bone mass. Secondary osteoporosis may be linked to different disease processes, such as chronic kidney disease, CKD, COPD, multiple myeloma, endocrine disorders, rheumatoid arthritis, and malabsorption syndromes. Osteoarthritis, or OA, is a chronic progressive degenerative joint disease. OA is the most common form of arthritis, and it's characterized by the gradual breakdown of cartilage in the joints. Over time, the loss of cartilage leads to bone-on-bone contact, causing pain, stiffness, and decreased mobility. OA mostly affects the knees, hips, hands, and spine. It is not systemic, it is localized to specific joints. Osteoarthritis develops through a slow, progressive deterioration process. Cartilage degeneration of the articular cartilage becomes soft, rough, and eventually wears away. It causes a loss of cushioning, and then the bones rub against each other. Osteophytes or bone spurs may form as the body tries to repair the damage. Joint space narrows due to cartilage loss, and bone thickness occurs. Synovial inflammation or mild inflammation may occur, adding to pain and swelling. Muscle weakness may occur due to reduced joint use or muscle atrophy. The disease progresses slowly over years. OA is caused by a combination of wear and tear from aging, previous joint injuries, genetic predisposition, obesity due to the added mechanical stresses, repetitive joint stress from occupational or sports, congenital or structural abnormalities. Risk factors are being age 50 and over, female sex has a higher prevalence after menopause, obesity, previous fractures or joint trauma, occupational overuse where frequent kneeling, bending, or lifting occurs, a sedentary lifestyle, family history, muscle weakness around the joint. Signs and symptoms are joint pain that worsens with activity and improves with rest, morning stiffness for approximately 30 minutes after waking, crepitus, swelling or tenderness, reduced range of motion, joint deformity in the late stages, and functional decline. OA is often asymmetrical, meaning one side of the body can be affected more than the other. Physiological impact is decreased mobility, endurance, and strength, difficulty performing ADLs, increased fall risk, decreased joint stability, sleep disturbances secondary to pain, muscle weakness and stiffness, potential weight gain due to inactivity. Psychosocial impact is frustration and discouragement over chronic pain, social withdrawal due to mobility limitations, loss of independence, anxiety about progression or disability, depression related to chronic illness, changes in roles, such as needing help with household tasks and caregiving. Elderly considerations. Older adults are more vulnerable because of advanced cartilage wear, decreased muscle strength, balance impairments, higher fall risks, polypharmacy concerns, and more severe functional limitations. Nursing considerations for the elderly. Use caution with NSAIDs due to risk of GI bleed and kidney issues. Encourage low-impact exercises such as walking or swimming. Promote weight management. Assess home safety, grab bars, fall prevention. Support use of assistive devices, such as canes or walkers. Diagnostic testing may be x-rays for joint space narrowing and osteophytes, or an MRI for cartilage or soft tissue detail. Lab testing. While OA does not have specific blood markers, it's used mainly to rule out rheumatoid arthritis or infection by getting a CBC, an ESR, and a CRP. Physical exam will include joint palpitation, range of motion, strength, and gait assessment. First-line non-pharmacological treatments, weight loss to reduce joint load, heat therapy such as warm showers or heating pads, cold packs for swelling, physical therapy, gentle exercise such as swimming or Tai Chi, strengthening exercises for supporting muscles, assistive devices, occupational and physical therapy. Pharmacological, acetaminophen is the first line, especially in older adults. Use NSAIDs cautiously. Topical analgesics, such as um, doflanac gel or capsaicin, hydrocortisone injections for severe flare-ups, or hyaluronic acid injections, such as Gel 1. Surgical joint replacement for hips and knees for severe OA, or joint arthroscopy for limited benefit but used in select cases. For the nursing process, you're going to assess the pain level, location, and characteristics, the mobility and gait, the functional ability and ADLs, joint swelling or deformity, impact on sleep and daily living, medication use and side effects, fall risk assessments, nursing diagnosis, chronic pain, impaired physical mobility, self-care deficit, activity intolerance, and risk for falls. Planning and goals, reduce pain to tolerable level, improve mobility and joint function, maintain independence in ADLs, prevent falls and injury, and enhance coping and psychological well-being. Some interventions: administer analgesics as prescribed, apply heat or cold therapy, teach proper body mechanics, encourage weight reduction, promote safe exercise program, assist with mobility devices, provide emotional support, collaborate with PT/OT, and monitor for NSAID side effects. For evaluation, was the pain controlled? Does the patient have improved mobility and gait? Has the patient demonstrated safe body mechanics? Is there an increase in independence with ADLs? And has the mood and engagement improved? Environmental factors affecting mobility. Environmental factors are external conditions in the client's surroundings that can either support or hinder safe movement. These factors are important to identify because they contribute to falls, injury, fear of movement, and decreased independence. Physical environmental barriers, such as cluttered or crowded living spaces, cords, rugs, furniture, or belongings, may obstruct walking pathways. This increases risks of falls and fear of moving around independently. Poor lighting, especially dim hallways, bedrooms, or bathrooms, reduces visibility. There's a higher risk for tripping and misjudging steps. Unsafe flooring. Slippery floors, uneven surfaces, or even loose rugs can cause falls. It is especially dangerous for the elderly and clients using assistive devices. Stairs and lack of handrails. Stairs may be difficult or unsafe for clients with limited mobility or pain. Absence of handrails reduces support and stability. Assistive device barriers. Improper walker, cane, or wheelchair fit. Incorrect height or worn rubber tips can increase fall risks. Clients may avoid using devices if uncomfortable. Lack of mobility aid. Some clients do not have access to walkers, canes, or grab bars. Broken or poorly maintained equipment, malfunctioning wheelchairs, or missing wheelchair brakes create hazards. Institutional or hospital environmental barriers. The bed height too high or too low. Room layout. Lack of call bell within reach. Social and support environment, a lack of family support. Clients without assistance may fear or resent moving. Overprotective caregivers may discourage mobility and increase dependence. Cultural beliefs of some clients view rest as necessary for healing and resist movement. Nursing interventions. You already have encouraged mobilization, assessed mobilization needs, and used bedside mobility tool. Here are environmental focused interventions that can complement those. Modifying the environment by ensuring adequate lighting, removing clutter and hazards, and arrange frequently used items within reach. Ensure assistive devices are safe and appropriate. Inspect equipment regularly for safety. Promote safe pathways by keeping hallways clear and encouraging non-skid footwear. Encourage clients and family to teach the importance of mobility and how it affects safety. Encourage the use of grab bars, handrails, and mobility aids. Support clients emotionally by hearing their fears of falling and offering reassurance and supervised practice. Equipment may be needed to aid in mobilization safely. Equipment is necessary to keep both the client and the nurse safe during mobilization. Healthcare settings may require attendance at workshops aimed at reducing workplace injury during mobilization. It is the nurse's responsibility to ensure understanding on how to use any equipment that is available for clients' mobilization within their workplace environment. The nurse's role in managing mobility includes educating the client about mobility, including the importance of mobilization, the expected movement, as well as the technique or processes of mobilization. Clients often perform mobility tests better when the nurse does the exercises with them. Assess the client's cognitive status, sensory ability, and balance to determine if it is safe for the client to mobilize independently. In addition to early ambulation, encourage clients who are able to sit in the chair for meals and to perform self-care activities as independently as possible. Pain management is essential to ensuring the client can be active and have adequate sleep. Fall prevention and other safety measures are an important role of the nurse for the client with problems with mobility. Assist and evaluate the client's ability to safely use walking aids. Client education is essential in helping patients safely increase mobility, prevent complications, and regain their independence. Explain the purpose of mobility. Movement helps maintain strength, circulation, and lung expansion. Teach safe mobility techniques, such as rising slowly to prevent dizziness, wearing non-skid footwear. Pain management and mobility. Encourage movement after pain medication when appropriate. Discuss that gentle movement can actually reduce pain long term. Avoid hazards by ensuring adequate lighting and keeping pathways clear. And educate on when to seek help. Sudden weakness, new or increasing pain, numbness, tingling, or dizziness. Empower clients to understand why mobility matters and how to move safely. Falls are a major risk for hospitalized, elderly, and mobility impaired clients. Prevention protects patient safety and helps avoid long recovery times or new injuries. Keeping the bed in the lowest position with the brakes on. Ensure call bell and essentials are within reach. Maintain clear pathways. Use adequate lighting, especially at night. And install or encourage use of grab bars and hand bars. Physical safety measures may include the use of non-skid socks or shoes. Encourage slow, steady movements and standing up gradually. Provide assistive devices and ensure proper sizing. Apply gait belts during transfers if needed, and encourage clients not to ambulate alone until safe. Nursing actions, perform a fall risk screening. Reassess after medication changes, such as sedatives or opioids. Respond promptly to call lights to prevent unsafe attempts at mobility, and teach family and caregivers safe support techniques, all with the goal of reducing the risk of injury and promoting safe independence. The importance of mobility. Mobility is vital for preventing complications and maintaining physical and psychosocial health. Physiological benefits include prevents muscle atrophy, improves circulation and reduces the risks of DVTs, it enhances lung expansion and prevents atelectasis and pneumonia, supports digestion and reduces constipation, improves joint flexibility and decreases stiffness, helps maintain bone density, and promotes faster recovery after illness or injury. Psychosocial benefits increases confidence and independence, reduces anxiety and feelings of helplessness, improves mood through movement and social interaction, helps maintain daily routines and self-care abilities. Consequences of immobility: pressure ulcers, deconditioning, pneumonia, blood clots, depression, withdrawal, and increased dependence on others. The goal is to encourage consistent, safe mobility to improve overall well-being. Nursing strategies to promote mobility: assess client readiness and ability to mobilize. Use a bedside mobility tool or facility algorithm. Encourage gradual increases in activity. Collaborate with PT and OT. Provide rest periods to avoid fatigue. And reinforce safety and proper body mechanics and the use of the safety devices. Let's take a few minutes to discuss fractures. Fractures are a common condition that you will encounter in long-term care, acute care, outpatient settings, and rehabilitation. As frontline caregivers, you play an essential role in recognizing fractures, supporting pain management, monitoring for complications, and promoting safe mobility and healing. A fracture is a break in the continuity of a bone. Fractures can occur from trauma such as falls, accidents, or sporting injuries, pathological conditions, osteoporosis, cancer, or bone disease, and overuse stress on weight-bearing bones. You must remember that fractures are not always caused by major trauma. Elderly adults can sustain fractures from minor falls due to bone fragility. Some common types of fractures. A closed, simple fracture. The bone is broken, but the skin does not break. Lower risk of infection. An open or compound fracture. The bone breaks through the skin. This has a high risk of infection and requires immediate medical and surgical intervention. A green stick fracture is an incomplete break, like a bent branch. This is common in children. A comminuted fracture is where the bone shatters into many pieces, and this often requires surgery. A spiral fracture is where the bone is twisted apart. This is often due to rotational injuries. Impacted fracture is where the ends of the bones are forced together. A stress fracture is a small crack caused by repeated stress, often seen in athletes or workers with repetitive activities. Clinical signs and symptoms of a fracture may include pain, severe unrelieved by rest, swelling and bruising, deformity or abnormal alignment, limited mobility, crepitus, shortening or rotation of the limb, loss of function, or an open wound in a compound fracture. As an LPN, you must assess circulation, movement, and sensation. These are called CMS checks. Some common complications of fractures. Compartment syndrome is a medical emergency caused by swelling that's created pressure inside the muscle compartments. Symptoms are severe pain out of proportion, tingling, numbness, pale skin, and weak pulse. Never elevate the limb. If suspected, notify the RN or provider immediately. A fat embolism syndrome. Fat globules enter the bloodstream after long bone fractures. Signs and symptoms: sudden respiratory distress, confusion, petechiae on chest and neck, if this requires emergency interventions. Infection, especially with open fractures. Watch for redness, warmth, fever, and drainage. Delayed union or non-union. This is where the bone takes longer to heal or fails to heal completely. A deep vein thrombosis, related to the immobility after a fracture. Monitor for swelling, warmth, and pain in extremities. Treatment of fractures depends on the severity and the type of fracture. Immobilization can include splints, casts, slings, and immobilizers. Traction can be skin or skeletal, and it helps align bone and reduce muscle spasms. Surgery, ORIF, is open reduction internal fixation or external fixation devices, and even possibly a joint replacement, such as in a hip fracture in an older adult. The LPN nursing care of patients with fractures. Provide initial care. Support limb above and below the fracture site. Maintain alignment. Apply ice if ordered, and complete CMS checks frequently, comparing both limbs. Cast care. Keep cast dry and clean. Do not insert objects into the cast, and report increasing pain, foul odor, hot spots, numbness, or swelling. Traction care. Maintain prescribed weights, never remove them. Ensure ropes move freely, and skin assessments for breakdown. Post-operative care. Manage pain, reinforce dressings, monitor for bleeding, swelling, or infection, encourage early mobility as allowed, and teach incentives for deep breathing for prevention of pneumonia. Mobility and safety, teach use of assistive devices, fall prevention strategies, and encourage range of motion exercises on unaffected limbs. Patient education, proper cast care, weight-bearing instructions, medication use for pain meds and anticoagulants as ordered, signs of complications, nutrition for healing to include protein, calcium, and vitamin D, and the importance of keeping follow-up appointments. Special considerations in older adults. Older adults are at higher risk due to osteoporosis, falls, slow healing, and increased risk of immobility complications. A hip fracture is a break in the upper portion of the femur, typically occurring at the femoral neck most commonly, the intertrochanteric region, or the subtrochanteric region. Hip fractures are medical emergencies, especially in older adults, due to the high risk of complications and rapid functional decline. A hip fracture occurs when force exceeds bone strength. In older adults, bone strength is reduced due to osteoporosis, decreased bone density, muscle weakness, and loss of protective reflexes. When a fracture occurs, the bone ends may displace. Bleeding into surrounding tissues causes swelling and pain. The inflammatory response activates, which causes more swelling, and thus limited mobility. And weight bearing becomes impossible. Hip fracture rapidly impacts mobility, cardiovascular stability, respiratory function, and independence. Most common cause, falls, especially sideway falls, osteoporosis related to fragility fractures, and direct trauma. Less common causes, pathological fractures due to cancer, bone cysts, or metabolic disorders. Risk factors are older age, osteoporosis, history of falls, medications causing dizziness, visual impairment, muscle weakness, chronic medical conditions, malnutrition, smoking and alcohol use, and a low body weight. Signs and symptoms will be severe hip or groin pain, inability to bear weight. Affected leg appears shortened or externally rotated, bruising or swelling, pain that increases with movement, muscle spasms, limited range of motion. Hip fractures carry high complication risks, especially in older adults. The physiological complications are DVT or pulmonary embolism, pneumonia due to immobility, pressure injuries, blood loss resulting in shock, infection, fat embolism, and muscle weakness and contractures. Psychosocial complications, fear of falling again, loss of independence, depression or anxiety, long-term disability, increased reliance on caregivers or long-term placement. Hip fractures significantly increase mortality in the first year, primarily due to complications from immobility. The first-line diagnostic testing is an X-ray, an MRI if a fracture is suspected but not visible on an X-ray, or a CT if needed. Labs, a CBC for blood loss and infection, electrolytes, and a coagulation pre-surgically. Treatment, surgical repair is most common and preferred, an ORIF, or a hemiarthroplasty, or even a total hip arthroplasty. Early surgery within 24 to 48 hours improves outcomes. Non-surgical treatment, used only in patients too unstable for surgery, is bed rest, traction, and pain management. Note that these patients have a much higher risk of complication. The nursing process for a hip fracture: assess pain level and location, neurovascular status of affected and unaffected limb, leg shortening and rotation, mobility level and fall history, surgical wound of post-op, respiratory status, skin integrity, vital signs, and psychosocial concerns. nursing diagnosis, acute pain, impaired physical mobility, risk for falls, risk for infection, self-care deficit, anxiety, and risk for impaired skin integrity. Planning and goals. Pain control, prevent complications of immobility, maintain skin integrity, promote safe mobility, demonstrate proper hip precautions if applicable, prevent falls, and patient participates in rehab. Interventions, pain management, mobility and safety, avoid crossing your legs post-op, avoid bending over 90 degrees, and use an abduction pillow. Encourage early ambulation with PT, use gait belts and assistive devices, keep call bell in reach, bed in lowest position, and pathways clear. Skin care, neurovascular monitoring, respiratory care, instead of spirometers, deep breathing and coughing, and keep the head of the bed elevated. DVT prevention using SCDs or compression stockings, hydration, anticoagulants if ordered in early ambulation, psychosocial support, and education. In the elderly, they have special considerations due to being a higher fall risk, fragility of bones, slower wound healing, increased risk for delirium post-op, higher complication rates, and increased mortality. Avoid oversedation, monitor for hydration and nutrition, reinforce frequent reorientation if confused, encourage safe early mobility with supervision, and review medications that increase fall risk. Early mobility helps prevent pneumonia, DVTs, PEs, constipation, muscle atrophy, pressure injuries, and loss of independence. Mobility improves strength, mood, function, and quality of life. Complications of fractures. Integumentary system. Risk for infection and open fractures. Open fractures allow bacteria to enter the wound. They require sterile dressing changes, monitoring for redness, warmth, drainage, and fever. Pressure ulcers can occur due to immobility, casts, and traction, which increase pressure on bony prominences. Frequent repositioning and skin checks are essential. Risk for atelectasis due to reduced mobility leads to shallow breathing. Encourage deep breathing exercises, coughing, and use of an incentive spirometer. Risk for pneumonia due to secretions pooling when the patients are immobile. Early mobilization and hydration help prevent infection. Sleep and rest disturbances. Pain, immobilization devices, and hospital routines can disturb sleep. Promote comfort, cluster care, and encourage relaxation techniques to improve rest. Bleeding. Fractures can damage blood vessels, causing internal bleeding, hematoma formation, or hypovolemic shock and severe trauma. Remember to monitor vital signs for tachycardia, hypotension, and pallor. Observe surgical sites or casts for bleeding or drainage, and document and report any changes promptly. Neurovascular compromise can occur caused by swelling, tight casts, or bone displacement, which affects blood flow or nerve function. The key assessment is CMS checks. Red flags are numbness or tingling, cold, pale skin, weak or absent pulses, inability to move fingers or toes. Immediate intervention is needed to prevent permanent damage. Compartment syndrome, which is a life-threatening emergency, occurs due to increased pressure within a muscle compartment that cuts off circulation. Common after fractures of the tibia or forearm. Classic symptoms are severe, unrelenting pain not relieved by medication, pain that increases with passive movement, tingling, swelling, and tightness. Do not elevate this limb, notify the RN or provider immediately, and prepare for possible fasciotomy. Embolism, a fat embolism syndrome, occurs when fat droplets enter circulation, common with long bone fractures such as the femur. Symptoms include sudden respiratory distress, confusion or restlessness, petechiae on chest, axilla, or conjunctiva, and requires emergency care. A venous thrombosis, such as a DVT or pulmonary embolism, occur due to immobility. Prevention is early ambulation, hydration, anticoagulants if ordered, and compression devices. Nursing considerations for traction and fracture management include making sure the joint remains immobile while assessing for and preventing complications. Complete your CMS checks. Monitor for complications. Stabilize the client prior to immobilization of a fracture. Let's focus on the nursing process. Recognizing cues means what are you looking for? These are often early indicators that something is wrong. An increasing pain not relieved by medication, pain that worsens with passive movement, or pain out of proportion to the injury could be indicative of compartment syndrome. Numbness, tingling, burning sensations could be indicative of neurovascular compromise. Changes in appearance, such as new swelling or rapidly increasing swelling, pale or dusky skin, cool skin temperature, obvious deformity or misalignment, or unusual bruising could indicate bleeding, vascular impairment, or infection. Inability to move a limb, new weakness, or pain with movement could indicate a worsening fracture, a nerve injury, or compartment syndrome. Vital signs to be careful with: a fever could be an indication of an infection, tachycardia could be bleeding or early shock, and low O2 sats could be a fat embolism or a respiratory decline. In your focused assessment, what should you be doing? Neurovascular assessment to include frequent CMS checks during the first 24 to 48 hours, in which you are checking the circulation by observing Keller, capillary refill, pulses, and skin temperature. Movement. Can your patient move their fingers and toes? Do they have any new reports of numbness, tingling, or new pain? Document changes and report immediately. Be sure to use a consistent pain scale of 0 to 10, in where you assess the location, quality, severity, what makes it better or worse, and response to any analgesics. Persistent or worsening pain is a red flag. Be sure to do a skin assessment and check for redness, warmth, or drainage. Check the skin around casts, splints, and traction boots. Inspect pin sites, if applicable, and assess for pressure ulcers due to immobility. A respiratory assessment is important when mobility is limited. Look for shallow breathing, shortness of breath, crackles, or low O2 sats. These may indicate atelectasis, pneumonia, or a fat embolism. In your musculoskeletal assessment, compare limbs bilaterally, look for deformity or shortening, observe abilities to bear weight, and assess posture and limb alignment. Your priority cues to report immediately are severe escalating pain unrelieved by medication, cool, pale, or pulseless extremities, numbness or tingling, inability to move the limb, excessive bleeding, sudden respiratory distress, petechiae on the chest, neck, and upper body, increasing swelling despite elevation. These may indicate compartment syndrome, neurovascular compromise, hemorrhage, or embolism. At this stage, the nurse analyzes the assessment data, connecting the cues to potential complications and determining what requires the most urgent attention. Pain is expected, but uncontrolled or escalating pain is a warning sign. Severe, persistent, or pain worsened by passive movement may indicate compartment syndrome, poor alignment, pressure from cast or splint. The priority hypothesis: is the pain typical for the injury, or does it indicate a complication? Compromised neurovascular status. Based on cues such as numbness and tingling, weak or absent pulses, pale or cool extremities, delayed capillary refill, increased swelling. This is a high priority hypothesis as it suggests compartment syndrome, circulatory obstruction, or nerve damage. Compromised neurovascular status requires immediate reporting to prevent permanent damage. An embolism will have cues such as shortness of breath, low pulse ox, confusion or restlessness, chest pain, and petechiae on the upper chest or upper body. Hypothesis is a possible fat embolism due to a long bone fracture or a DVT or a pulmonary embolism due to immobility. Both are life-threatening and must be prioritized. Planning. Now the nurse creates goals and targeted interventions to address the prioritized hypothesis. Goals: free from complication, early recognition and prevention of infection, bleeding, compartment syndrome, and embolism. Maintain an open airway is especially important if suspected fat embolism or trauma. Maintain circulation to limb, frequent CMS checks, proper alignment, and reporting changes promptly. Maintaining alignment ensures immobilization devices remain properly positioned. Restore previous level of function. Early mobility when appropriate, physical therapy, and safe use of assistive devices. Example solutions such for planning interventions. These will connect back to your earlier prioritized areas. Pain management. You're going to administer analgesics, reposition limb for comfort, elevate limb if appropriate, and assess pain frequently. Neurovascular protection, performing CMS checks every 1 to 2 hours initially, loosen tight bandages if permitted, keep limb aligned and supported, and report any abnormal findings immediately. Preventing embolism by deep breathing and coughing, promote early mobilization when appropriate, hydration to prevent blood viscosity, and administer anticoagulants if ordered. Evaluation is the final step in the nursing process and the clinical judgment model. Here, the nurse determines whether the interventions were effective, if the goals were met, and whether the patient is improving, declining, or unchanged. For a patient with fracture, with or without traction, the LPN focuses on the outcomes related to pain, neurovascular status, mobility, respiratory function, and complication prevention. Pain management outcomes. The desired outcome would be the patient reports reduced pain to an acceptable level, pain is stable, predictable, and responds to medication and positioning. So your evaluation questions would be, did the pain rating decrease after medication or repositioning? Is the patient able to rest or sleep? Are there any new or worsening pain cues that may signal a complication? The desired outcome for the neurovascular status is adequate circulation, movement, and sensation maintained in affected limb. Your evaluation questions would be, are pulses present and strong? Does the patient have normal movement and sensation? Has swelling decreased or stabilized? Has the risk of compartment syndrome been minimized? If CMS assessments show improvement or stability, the goal has been met. If deficits appear or worsen, immediate escalation is required. Airway and respiratory outcomes are especially relevant when assessing for fat embolism or immobility-related issues. The desired outcome, airway remains patent, breathing is unlabored, and no signs of respiratory distress. Questions to ask: has the patient maintained normal oxygen saturation? Is the breathing pattern regular? Are breath sounds clear? Any new cues of dyspnea, tachypnea, confusion, or petechiae? If the respiratory status is stable, your goal's been achieved. If there's respiratory decline, it requires immediate reporting. The desired outcome for circulation and limb perfusion would be adequate blood flows maintained to the extremity. Questions to ask: Keller normal? Temp normal? Is there reduced swelling? Are there any signs of bleeding or hematoma formation? Are vital signs stable? Alignment and immobilization desired outcomes would be that the bone and limb alignment is preserved, traction or mobilization device functions properly. Questions: are traction weights hanging freely? Has the patient remained in proper alignment? Is the cast or splint intact and not causing pressure points? The desired outcome for function and mobility is that patient begins to regain mobility and work toward previous level of function. The questions asked would be, is the patient participating in physical therapy as tolerated? Is mobility improving within expected timelines? Does the patient demonstrate safe use of assistive devices? The desired outcome for the absence of complications is that the patient remains free from infection, embolism, pressure injuries, and other complications. Questions would be, are applicable pin sites dry and clean? Has the patient remained afebrile with no redness or drainage? Is there any calf pain, swelling, or respiratory issues indicating a DVT or a PE? Is the skin intact without pressure ulcers? The desired outcome for patient education and engagement is that the patient understands care instructions, restrictions, and warning signs. Evaluation questions. Can the patient verbalize signs of complications, cast or traction care, when to call the provider, and is the patient compliant with activity restrictions and exercises? The nurse determines whether the interventions are effective and then can continue interventions, modify the plan as needed, escalate the concerns to the RN or provider, and document the outcomes and the patient response. The pathophysiology of back pain results from irritation, inflammation, or compression of structures in the spine or surrounding tissues. These structures include the vertebra, intervertebral discs, muscles and ligaments, facet joints, and spinal nerves. The underlying mechanisms: muscle strain is microscopic tears, inflammation, and pain. Disc degeneration is loss of disc height resulting in nerve compression. A herniated disc is the disc material protrudes and presses on nerves. Arthritic changes, bone spurs cause narrowing in the spinal canal, stenosis, and poor alignment, which increases mechanical stress on the spine. Pain occurs when nerves are irritated due to inflammation, pressure, or chemical irritation. The causes of back pain may be mechanical, degenerative, traumatic, structural, inflammatory, or referred pain. Mechanical causes are the most common cause. These include muscle strains or sprains, poor posture, prolonged standing or sitting, improper lifting, and sudden twisting movements. Degenerative causes are osteoarthritis, degenerative disc disease, and spinal stenosis. Traumatic causes include falls, accidents, and sports injuries. Structural is scoliosis, herniated discs. Referred pain can be from kidney stones or infections or gynecological issues. Inflammatory systemic causes are ankylosing spondylitis, osteomyelitis, or in rare cases, tumors. Risk factors: age, because degeneration increases over time. Obesity increases strain on the spine. A sedentary lifestyle. Weak core muscles. Occupational hazards that have heavy lifting, frequent lifting, or bending. Smoking, as it reduces blood flow to discs. Osteoporosis, poor posture, and chronic stress due to muscle tension. Back pain is one of the leading causes of functional limitations due to difficulty walking, sitting, or standing, trouble sleeping or resting, and the decreased ability to perform ADLs or work. It impacts the quality of life due to chronic pain, reduced mobility, and anxiety or depression. The economic impact is missed work, medical costs, and long-term therapy needs. For diagnostic testing, a physical exam in which the gait, posture, and range of motion is assessed, palpation of muscles for tenderness, and checking reflexes for strength and sensation. An X-ray may be taken to detect fractures, osteoarthritis, or alignment issues. An MRI is best used to view discs, nerves, and soft tissue. A CT scan is a good alternative if an MRI is unavailable. And a bone scan is used for infection, fracture, and trauma. Some labs to test for infection or inflammation would be CBC, ESR, CRP, and urinalysis. Treatment depends on the cause, but focuses on reducing pain and restoring function. The conservative first-line treatments would be rest for short-term only, heat or cold therapy, NSAIDs or acetaminophen, muscle relaxers, topical analgesics, physical therapy, stretching and strengthening exercises, postural correction, or weight loss counseling if needed. Interventional would be steroid injections or nerve blocks. Surgical is reserved for severe cases. such as herniated discs that cause severe nerve compression, spinal stenosis, instability, or progressive neurological loss, such as foot drop. The nursing process. You are going to assess the pain on a 0 to 10 scale to include location and duration, the type of pain, whether it's dull, sharp, radiating, or burning, the history of any injuries or lifting, functional ability to include walking, bending, and sitting, posture and gait inspection, neurovascular assessment, bowel and bladder changes, which can be a red flag, and sleep disturbances related to pain. Your nursing diagnosis may include acute pain, impaired physical mobility, risk for falls, risk for impaired skin integrity if immobility is present, sleep pattern disturbance. Planning and goals would be to reduce pain to a tolerable level, maintain mobility as tolerated, prevent complications of immobility, improve posture and body mechanics, and promote restful sleep. Some interventions: administer medications as ordered, apply heat or cold per protocol, assist with gentle stretching or PT exercises, teach proper body mechanics and lifting techniques, encourage walking and mobility, monitor for worsening neurological symptoms, provide a firm mattress for support or reposition for comfort, educate on weight control and core strengthening, and promote fall prevention if mobility is limited. Evaluation questions. Has the pain decreased? Has mobility improved? Can the patient demonstrate correct posture and lifting technique? Is the patient able to perform ADLs? Is there any new neurological deficits? Has sleep and comfort improved? The overall impact of back pain on the psychosocial, physiological, and elderly. The physiological impact of back pain can be significant and affect normal body functions. Persistent or severe pain can lead to decreased mobility and a risk for deconditioning, sleep disturbances, and can increase the risk of secondary conditions such as constipation, muscle spasms, reduced cardiovascular endurance, risk for pressure injuries and severe immobility, and decreased appetite or nutritional deficits. The effects of chronic pain can include changes in posture or gait, persistent inflammation or nerve compression, and potential progression to neuropathic pain. Psychosocial impacts of back pain affect more than just the physical health. They often influence emotional well-being, relationships, employment, and independence. The emotional effects may be frustration due to persistent symptoms, anxiety over the ability to work and recover, fear of re-injury, or depression related to the loss of independence and chronic discomfort. Social impact could be reduced social interaction due to mobility limitations, avoidance of activities enjoyed before the pain began, dependence on others for daily care, and role changes within the family. Occupational impact can include missed workdays, difficulty with job tasks requiring lifting, standing, or prolonged sitting, job loss, or the need for alternative employment in severe cases. Back pain is one of the leading causes of decreased quality of life due to persistent discomfort, fatigue, reduced mobility, and loss of independence. Back pain is especially significant in older adults due to age-related changes and increased vulnerability. Age-related physiological changes, such as degenerative disc disease, osteoarthritis of the spine, osteoporosis, which increases the risk of compression fractures, decreased muscle mass and flexibility, and reduced balance and stability. These conditions make older adults more likely to develop back pain and suffer more complications. The elderly have an increased risk of falls because the pain affects gait and posture. They have a fear of falling because it leads to decreased mobility, which is further muscle weakness, and falls can result in fractures, hospitalization, and further disability. Polypharmacy concerns exist because older adults may already be taking multiple medications, so there's a risk of interactions with analgesics, NSAIDs can cause an increased risk of GI bleed and renal impairment, and sedating medications may cause confusion or increase fall risks. The elderly have slower healing due to decreased blood flow to tissues, chronic diseases, and nutritional deficiencies. These factors prolong recovery from back pain or related injuries. Psychosocial concerns in the elderly is the fear of losing independence, isolation due to mobility limitations, depression related to chronic pain, and increased reliance on caregivers. Nursing considerations for elderly patients: assess, screen for red flags such as new weaknesses or bowel and bladder changes, assess for falls, gait instability, and environmental hazards. Evaluate pain realistically. Older adults may underreport. Encourage gentle mobility to prevent deconditioning. Use heat and cold therapy carefully due to thin skin. Assist with safe transfers of mobility. And provide hydration and adequate nutrition. Monitor for adverse medication effects. Teach proper body mechanics and posture. And collaborate with PT and OT for strengthening and fall prevention programs. Reinforce safe home environments with education. Encourage strengthening of core muscles. Provide strategies for pain management. And encourage maintenance of social activities as tolerated. Back pain affects patients physically, mentally, socially, and functionally. Older adults are at a higher risk for serious complications, slower recovery, and psychosocial effects. You will play a vital role in assessment, prevention of complications, promotion of mobility, and emotional support. An amputation is the surgical or traumatic removal of a limb or body part. The goal of a surgical amputation is to remove diseased or damaged tissue to prevent further infection and preserve as much function and mobility as possible. Amputations may be required due to poor circulation, such as peripheral artery disease or peripheral vascular disease, diabetes, infection such as osteomyelitis, gangrene, or severe wound that will not heal, trauma such as a crush injury, severe fractures, motor vehicle accidents, or industrial injuries, malignancy such as bone tumors or soft tissue cancers, congenital conditions such as limb deformities which cause impaired mobility. Types of amputations. Upper extremities may include fingers, hand or wrist disarticulation, below elbow, transradial, or above elbow, transhumeral. Lower extremities may include a toe, a foot partial amputation, a below the knee or BKA, or an above the knee or AKA. Lower extremity amputations are the most common, especially in diabetics. The underlying process leading to an amputation would be ischemia, in which the tissues starve of oxygen and therefore have cell death, infection that has spread to the bone or tissues, resulting in necrosis, trauma, which destroyed the blood supply, nerves, and structures, or chronic disease, prolonged inflammation, or poor healing. Once tissue becomes necrotic, it cannot be saved. Risk factors: diabetes, smoking due to vasoconstriction, which results in poor circulation, peripheral artery or vein disease, trauma, advanced age, exposure to frostbite or severe burns, obesity, and poor glycemic control. Some complications of amputation. Early complications would be hemorrhage, infection, shock, DVT due to immobility, or poor wound healing. Late complications, contractures, especially after BKA, phantom limb sensation or pain, chronic pain, delayed prosthetic fitting, or impaired mobility. Phantom limb sensation versus phantom limb pain. So the sensation is a non-painful feeling that the limb is still present. It may include tingling, pressure, or itching. Phantom limb pain is a painful sensation from nerves that are still sending signals. This is a stabbing, burning, or cramping. It's managed with medications, mirror therapy, and desensitization techniques. The psychosocial impact of amputation significantly affects emotional and social well-being. Emotional effects might be grief or loss, anxiety, depression, or fear of dependence, body image disturbance, such as changes in self-esteem or adjustment to altered appearance, social effects, such as role changes, transportation challenges, loss of independence, and the need for caregiver support. You should provide emotional support, active listening, and encourage open expression of feelings. Special considerations in the elderly are slower healing due to decreased circulation, higher risk for infection, a greater likelihood of chronic diseases, increased risk of falls, potential cognitive decline, more difficulty adjusting to prosthetic use, and needing extra time and repetition during teaching. Diagnostic testing would include a Doppler ultrasound to assess blood flow, arteriography, an X-ray, MRI, or CT for trauma or tumor, CBC, CRP, ESR for infection, and an A1C glucose level in diabetics. Treatment and management. In surgical care, the goal is to remove diseased tissue while preserving function, shaping the stump for prosthetic use. Pain management might include opioids for acute pain, gabapentin or antidepressants for phantom pain, ice if ordered, and positional changes, along with relaxation and distraction techniques. For wound care, monitor for redness, drainage, or odor, maintain a sterile dressing technique, and assess sutures or staples. Infection prevention might include antibiotics as ordered, blood sugar control in diabetics, and a clean, dry surgical site. Preventing contractures by avoiding placing pillows under the knee in a BKA. Encourage prone positioning if allowed, and range of motion exercises. Collaborate with PT and OT for mobility and rehabilitation, assist with transfer training, and encourage early mobilization as tolerated. Prosthetics restore the function and mobility. The LPN role is to monitor stump for tolerance, such as redness or breakdown, ensure correct prosthetic fit, and teach hygiene to clean the stump daily and dry completely. Encourage wearing schedules gradually and support emotional adjustment. For the nursing process, assess the pain level, including phantom pain. Assess the color and condition of the stump, the ability to perform ADLs, emotional response and coping, signs of infection, and fall risk. Nursing diagnosis might include acute pain, impaired physical mobility, risk for infection, disturbed body image, risk for impaired skin integrity, and self-care deficit. The goals would be pain control, stump healing without complication, patient safely mobile with assistive devices, preventing contractures, accept body image changes, and have the patient demonstrate correct stump and prosthetic care. Interventions: administer medications as ordered, perform range of motion exercises, encourage mobility with assistive devices, educate on prosthetic use, provide emotional support, and reinforce physical therapy plan. Evaluation: has the wound healed? Is the pain improved or controlled? Is the patient independent with transfers? Are there any signs of infection? And has the patient demonstrated coping and ability of self-care? An amputation affects a person far beyond the loss of a limb. It influences physiological functioning, psychological well-being, mobility, social participation, and long-term health outcomes. Understanding these impacts helps nurses provide holistic, compassionate, and effective care. The physiological impact is altered mobility, difficulty walking or performing ADLs, increased risk of falls, need for assistive devices or prosthetics, and slower movement and reduced endurance, muscle weakness and deconditioning, higher risk of fatigue and declining overall fitness. Cardiovascular effects: immobility increases risks of DVTs, PEs, and poor peripheral circulation. Skin and wound health: pain and sensory changes, such as phantom limb pain, neuropathic pain, residual limb discomfort, and disturbed sleep and decreased quality of life. Many amputees have diabetes or vascular disease, which affects healing time, infection risk, and the need for ongoing monitoring. The psychosocial impact: that an amputation involves is significant emotional and identity adjustment, body image disturbance, emotional effects such as grieving or mourning the lost limb, withdrawing from activities or community involvement, loss of role or independence with the inability to return to work or hobbies. The functional and daily living impacts. ADL challenges might be faced, especially with driving and home maintenance. They will have adaptive needs for home modifications and a need for occupational therapy. They will also have a need for prosthetic training, which requires time, patience, and consistent therapy. Not all amputees tolerate prosthetics well. Poor fitting prosthetics lead to skin breakdown and pain. Older adults face added challenges due to other age-related issues and chronic diseases, such as slower healing and recovery, increased fall risks, cognitive changes, emotional vulnerability, and polypharmacy risks. The long-term health impact is an increased energy expenditure. Walking with a prosthetic, especially an above-the-knee prosthesis, requires more energy, which leads to fatigue more easily. Joint strain from overuse of the intact limb can cause hip and knee arthritis, back pain, and muscle imbalance, and the risk of a second amputation, particularly in diabetic patients. Chronic disease management often signals in chronic disease management, amputation often signals advanced disease. Amputation affects every dimension of health. The physiological mobility limitations, pain, cardiovascular strain, and skin breakdown. Psychosocial, they have grief, depression, and loss of independence. Functional, they may struggle with ADLs or need assistive devices at home or home modifications. The elderly have slower healing, cognitive decline, and fall risk. Long-term increased energy demands, joint strain, and chronic disease progression. You want to collect both subjective and objective data. A physical assessment inspecting the residual limb or stump for redness, warmth, swelling, drainage or foul odor, signs of infection, or skin breakdown or pressure areas. Assess pain, both incisional, phantom limb pain, and phantom limb sensations. Check for adequate circulation with Keller, temperature, and capillary refill. Assess mobility or activity intolerance or tolerance, and monitor for complications. The functional assessment is the ability to perform ADLs, the ability to use mobility aids, balance and gait if ambulating, and tolerance to physical therapy. Psychosocial assessment is emotional reactions such as anxiety, grief, and depression, concerns about body image, support systems, and family/caregiver involvement, and the readiness to learn prosthetic care. Your nursing diagnosis. Common diagnoses for clients with amputations include acute pain, risk for infection, impaired physical mobility, disturbed body image, self-care deficit, risk for impaired skin integrity, anxiety, and risk for falls. In planning, short-term goals will be focused on pain control, residual limb will remain free from infection, and client will participate in range of motion and mobility exercises daily. Long-term goals, client will learn proper stump and prosthetic care, client will maintain skin integrity and prevent contractures, client will safely ambulate using appropriate assistive devices, client will adapt to altered body image and express acceptance, and client will return to the highest possible level of independence. Interventions for pain management. Opioids early on and gabapentin for neuropathic pain. Use non-pharmacological measures such as repositioning, massage if allowed, and relaxation techniques. Provide education and reassurance, and encourage distraction techniques. Wound and skin care include inspection stump daily and with each dressing change. Use sterile technique. Monitor for redness, swelling, odor, and drainage. Maintain stump wrapping or shrinker sock to shape limb for prosthetic use and keep skin clean and dry. Preventing contractures by encouraging prone positioning if permitted. Avoid placing pillows under the knee in a BKA and perform or assist range of motion exercises. Promoting mobility and rehabilitation by collaborating with the PT and OT, and fall prevention. Provide psychosocial support with active listening and feeling validation. Encourage expression of grief and concerns. provide information about support groups, and promote involvement from family or caregivers. In education, be sure to teach about stump care and hygiene, safe prosthetic use, signs of infection or skin breakdown, importance of exercise and circulation, medication use and side effects, and diabetes management if applicable. For evaluation and determining whether goals were met, for physical healing, is pain controlled? Is the incision healing without signs of infection? Is the stump properly shaped for prosthetic fitting? For mobility and function, is the client performing range of motion and mobility exercises? Is the client safely using assistive devices? Has gait improved since baseline? Skin integrity, is the skin intact and free of breakdown? Are there any ulcers or pressure areas from the prosthetics? Psychosocial adjustment, does the client verbalize acceptance of body changes? Is emotional distress reduced? Is the client participating actively in rehab and self-care? Education, can the client demonstrate stump care? Can the client identify signs of complications? Can the client safely transfer and mobilize with assistance? If outcomes are not met, revise the plan, collaborate with PT/OT, adjust pain management, and reassess barriers.